Good afternoon. I welcome one and all to this insightful session on the drugs related to the malignancies of male genitourinary system. With great pleasure, I welcome Dr. Vidit Kapoor, the program director for this session. Over to you, sir.
Dr. Shruti, shall we start?
Um, Sir, I
Thank
started.
you.
Am I not audible?
You are audible.
Yes,
Thank you, Dr. Shruti.
yes, sir. Thank you.
Uh, good afternoon, everyone. It is my pleasure and privilege to welcome you all again today for this session in the continuing E-Gurukul series, which is an online educational initiative that aims to provide high quality structured learning, not just for students and fellows, but also for practicing medical oncologists. And at the same time, hopefully, to foster a holistic academic environment where we can all learn together. So today's session will focus predominantly on drugs that are used in male genitourinary malignancies. And we know that in today's era, pharmacological strategies are transforming how we treat these cancers. Our discussion will include the mechanism behind these drugs, recent advancements in target therapies, and how these treatments can be incorporated into clinical practice to improve patient outcomes. And to guide us through this important discussion, we are honored to have with us Dr. Vinayak Maka, who is a renowned medical oncologist and currently professor and head of the Department of Medical Oncology at Ramaiah Memorial Hospital in Bangalore. So without waiting any longer, I would like to invite Dr. Vinayak to take stage and moderate the session. Thank you so much.
Thank you, Dr. Vidit. I'm Dr. Vinayak Maka. I'm senior professor. I'm no more HOD. But today, the discussion will be very interesting. In fact, the series of Gokul series is very good. It covered organ-wise drugs. So I would like to call our first speaker, Dr. Hemanth. He's a consultant medical oncologist and is working in Mangalore. He is very active academically. He was part of initial DM training programs. I know personally, and this will be good session for him. Dr. Hemanth, over to you.
So Dr. Hemanth is the mentor, so I'll request you to invite our speaker.
Sorry, ma'am. So, and I request our speaker, Dr. Chandralekha. She is working as assistant professor in medical oncology department in Stanley Medical College. Ma'am will be speaking about the session now. Dr. Chandralekha, can you take care?
Good afternoon, respected professors, eminent faculties present here. Thank you, Vinayak sir. Thank you, Vidit Kumar sir. I especially thank Dr. Shruti Gohel for coordinating the session. And we'll quickly move on to the session as such. So today's topic is on drugs in genitourinary cancer. So I'm covering urinary bladder, renal cell carcinoma, and testicular neoplasms also. So moving on. So this is the bladder cancer where we are covering the non-muscle invasive bladder cancer, muscle invasive bladder cancer, and metastatic setting. In the kidney, are going to speak about the adjuvant setting and the metastatic drugs used there. And in prostate, non-metastatic CRPC, CSPCs, where we are going to talk about this called docetaxel, cabazitaxel, and other drugs, other oral drugs which are used in prostatic setting. So next slide. So in non-muscle invasive bladder cancer, we have the concept of this intravesical therapy. So basically, this is drug-oriented session. I'm not going to speak more on the indications and the evidences. So only first is talking about the drugs and also those drugs which have been covered in the previous session. For example, gemcitabine and other immunotherapy, pembrolizumab, nivolumab, which has been covered in the lung cancer sessions and the GI cancer sessions. I'm not including it here. So moving on to the intravesical therapy, it is a single instillation of chemotherapy within 24 hours. It is preferable to get it done immediately post-operative within 6 hours. So the drugs used are the gemcitabine, mitomycin C. They are effective in low-grade, low-volume TA disease. This reduces the risk of recurrence by 35%. And the other drug, which is most commonly used, is the BCG drug. And one more thing is that these kind of patients land to us only after the installation therapy, or they are taken care by the urologist most of the time. But still, we need to know. Some patients do come to us, and still we need to know the schedule of these drugs. The BCG is initiated as a neoadjuvant setting or an adjuvant setting. It is initiated 3 to 4 weeks after the TURBT with or without maintenance. And it is given as a weekly regimen for 6 weeks. Next slide. So this BCG has to be withheld if there is any bacteriuria, hematuria, and symptomatic. And it should not be done. This kind of intravesical chemotherapy should not be done if any perforation has occurred during the procedure. And the maintenance therapy is as per the SWOG regimen. It is 3 weekly installation at 3, 6, 12, 18, 24, 30, and 36 months. And it is 1 year in case of intermediate risk and may be prolonged also in high risk patients. Next slide. So the mechanism of action of BCG is this infect the cancer cells that is mediated by the glycoprotein fibrin nectar, which allows the internalization of BCG and the breakdown of the proteins with the cellular changes where the antigen is expressed that triggers the immune system. This reacts similar to the action of a infection by a tuberculosis. So this combination of this direct effect on the tumor cells along with the patient's response to this drug is the action which is visible for our cancer chemotherapy. Next slide. So this preparation of BCG, usually it is, previously it was 120 milligram. Now, as per the American Urologist Association, it is recommended as 80 milligram. That comes as a separate vial as 20 milligram each. We dissolve this freeze-dried powder with the diluent. This solution is diluted to further 50 ml of normal saline. And because this preparation contains the live organism, care should be taken during the preparation, administration, and disposal of the supplies. Next slide. So this prepared solution is instilled into the either by our Foley's catheter or NG tube can also be used if it need a smaller tube, and it is clamped after the injection of this drug, and the patient is asked to move to the left and the right as we do for a pleurodesis procedure. The solution should be retained for 1.5 to 2 hours, after which the time the patient is asked to void. So, since the procedure goes on, that the intravesical chemotherapy contact should be there for 1.5 to 2 hours. Before that, the patient should be asked to void and come and take minimal amount of fluids also, so that she or he can hold the urine for 1.5 to 2 hours. And after this, tube is removed and the patient can be asked to void. Next slide. The induction phase is complete when the immunologic reaction is occurred. So how do we know this? The patient starts getting the irritative bladder symptom and the urine contain white blood cells without evidence of infection, and microscopic hematuria may be present. That immunological reactions have started occurring. Next slide. Moving on to the next drug, which is the mitomycin C. The dose of mitomycin C to be instilled is 4 mg per ml via the urinary catheter, and this mitomycin C usually is given immediately post-procedure by the urologist itself. Instillation of mitomycin C immediately post-procedure has a significant importance in the reduction of the recurrence rate. So the adjuvant therapy, which is followed after 3 weeks, is different, and the immediate drug that is installed immediate post-procedure is different, and this carries a special importance in the recurrence rate. So this is following that it should be instilled once weekly for 6 weeks. Next slide. So moving on to the systemic therapies used in the muscle invasive bladder cancer, these are the standard regimens recommended as gemcitabine cisplatin. So the dose and MVAC, how it came into evolution. Initially, it was the standard MVAC regimen. This MVAC regimen contains methotrexate, vinblastine, doxorubicin, and cisplatin. And this has been tried initially in the metastatic setting, and subsequently it has also been incorporated in the neoadjuvant setting also. And there were trials which had compared the cisplatin and gemcitabine combination along with the dose-dense MVAC, and though it has proven a superior recurrence-free survival with the dose-dense MVAC. So the first preferred regimen would be dose-dense MVAC. Otherwise, we have to classify the and one more thing to mention is that taking bladder into consideration, the first thing we have to think about is the Galski's criteria, that is the cisplatin eligibility criteria. So after seeing that, we have to proceed with the chemotherapy. And in those terms and MVAC, next slide. Next slide. Next slide. So the methotrexate is 30 mg per meter square. Ma'am, the previous slide. The methotrexate is 30 mg per meter squared, which is given on the day 1, which is as an IV push, and the vinblastine, which is 3 mg per meter squared on day 2. It is given in 50 ml NS over 15 minutes. And the doxorubicin, that is 30 mg per meter squared on the day 2, is as an IV push. And the platinum cisplatin, that is 70 mg per meter squared on day 2. So since we are giving 70 mg per meter squared of cisplatin, we have to take adequate precautions regarding the hydration and supplementing potassium chloride, magnesium sulfate, and mannitol as per the recommendations for a high cisplatin protocol. And subsequently, this DD-MVAC is repeated every 14 days for a period of four cycles. Since it is dose dense and platinum is high dose also, should take into consideration the risk of febrile neutropenia, and it is comes under highly emetic category and has a risk of more than 20% for the febrile neutropenia. So we are using prophylactic GCSF, which starts from the day 4, and it can be given up to day 10 and adjusted as per needed. Next slide. As of considering the MVAC, we have to prefer giving the MVAC based upon the creatinine clearance. So if it is more than 80%, give 100% of methotrexate. And if it is 60 to 79%, it is 75%. 51 to 60% is 70%. 10 to 15%. And less than 10%, better to avoid it. And the cisplatinum dose also definitely needs a creatinine clearance management. So above 60, you can proceed with 70 mg per meter squared. 45 to 60, proceed with 35 mg per meter squared on day 1 and day 2, less than 45. In subsequent cycle, it is better to delay for a week. And once the creatinine clearance is normalizing, we can proceed with the subsequent cycles. Next slide. So this is used in neoadjuvant setting and an adjuvant setting, and the usage of MVAC in a neoadjuvant setting in muscle invasive bladder cancer has shown a better disease-free survival than compared to considering it in a postoperative adjuvant setting. So trials I'm not quoting here and just telling about the points. And as already mentioned, dose-dense MVAC is better than MVAC alone. And subsequently, if you are not using a MVAC, dose-dense MVAC, it is preferred to use gemcitabine plus cisplatin. And one more important point is that carboplatin should not be replaced in borderline creatinine clearance. Is very important. And in case in older patients where it is not fitting, may be used as a category 2B recommendation. And those patients who have a borderline creatinine clearance, we can consider using a cisplatin, which is the split dose of cisplatin on the day 1 and day 2, or day 1 or day 8. Here is a mention about the Galski's criteria. I think everyone will be aware of that. We have to have a performance status of more than 2. Creatinine clearance should be more than 60, and there should be no more than grade 2 hearing loss, not more than grade 2 peripheral neuropathy, and there should be no documented class 3 heart failure. Next slide, please. Even one criteria, if it is present, they fall into as non-eligible for a cisplatin. Coming to the next step, which is the methotrexate. It is an antifolate analog active in S phase, and it has multiple actions, especially in low dose and high dose prescription. It also has it requires polyglutamation by the enzymes FPGS for its cytotoxic activity. Polyglutamation, especially in the high dose methotrexate, increases the intracellular pool of folates, and this polyglutamated folate are not easily transported out of the cells because of their size and charge. And because of this point, they stay in the cell for a longer time, especially in a high dose methotrexate, and that is the reason for the tumerocidal activity of a high dose methotrexate, and also for the toxicity associated with the high dose methotrexate also. And basically, it causes inhibition of the dihydrofolate reductase, resulting in depletion of critical reduced folates. Next slide. So it is extensively metabolized in the liver, and renal excretion is also the main route of elimination. And we know that adequate creatinine clearance should be there for the prescription of the methotrexate. And myelosuppression is a dose-limiting toxicity. And one more thing to be aware of methotrexate is about the mucositis, especially when given in high dose. And regarding the hepatotoxicity, there occurs a transient elevation in the serum transaminases and bilirubin with high dose chemotherapy, and it can occur in low dose also. And we have to wait for the hepatic enzymes and the bilirubin to normalize to proceed with the subsequent cycle of chemotherapy. Next slide. So basically, these are the toxicities associated with high dose methotrexate. Since we are talking about methotrexate, I'm also mentioning about the high dose toxicities. It is dermatologically, it is a Stevens-Johnson syndrome or erythema multiforme. Regarding the gastrointestinal, it is nausea, vomiting, and mucositis, as already mentioned. Hematological, it is severely myelosuppressive, causing neutropenia and thrombocytopenia. Hepatic, transient elevation of the transaminases. And neurologically, sometimes encephalopathy can occur, which may be transient. And pulmonary causes, it can rarely cause pneumonitis also. And renal, this is actually a word of mention that this is the most important. Acute kidney injury due to the precipitation of the crystals of the methotrexate can occur. Next slide. So the next drug in the MVAC is the vinblastine. So vinblastine is a sterile solution of vinblastine sulfate and sodium chloride. It is a vesicant, and if leakage occurs around the surrounding tissue, it should be discontinued immediately, and local injection of hyaluronidase with the application of heat has been used to disperse the medicine. And its dose-limiting toxicity is myelosuppression. Hence, since it causes myelosuppression, it should not be used when active infection is present. And one more thing is, this vinca alkaloid comes along with the vincrystal. And what is the difference between vincrystal and vinblastine is that one has the methyl group and another one has the aldehyde group, and they differ in their structure. They are isolated from the same Madagascar periwinkle plant, and since they are structurally different, their side effects and the indications where they are used is also different. Next slide, please. So as already mentioned, it causes myelosuppression, like leukopenia, which is more common than the thrombocytopenia. Sometimes it can cause acute shortness of breath and bronchospasm. And as such, there is no dose adjustment required in hepatic and renal failure. In renal failure, but there is dosage adjustment required in hepatic failure. Next slide, please. Coming to the aldriamycin, it is an anthracycline group of drugs. It acts by inhibiting the topoisomerase 2, thereby causing DNA damage. And early cardiotoxicity is the class hallmark toxicity of aldriamycin. So, word of mention about the toxicity of aldriamycin. So early cardiac toxicity, delayed cardiomyopathy. So early cardiac toxicity, how does it manifest? It may occur as a sinus tachycardia, ECG abnormalities, non-specific T waves. This is usually delayed cardiomyopathy is most common. This is manifested by reduction in the left ventricular ejection fraction. So basically, because of this cardiac toxicity, we need to do a baseline cardiac evaluation, avoid in patients who have lower ejection fraction, and during the chemotherapy also, frequent monitoring of the LVEF if necessary, and just address the symptoms of the patient and ask leading questions for the toxicity of this drug also. Next slide. So a word of mention about the adriamycin-induced cardiotoxicity. So basically, it is the production of free radicals that produces in the cardiac muscles after the doxorubicin administration. It occurs via there is actually depletion of the sarcoplasmic endoplasmic reticulum, that is decreased SER, and there is alteration in the calcium dysregulation. This results in the cardiac toxicity, leading to apoptosis and the cardiomyopathy changes. So basically, it is the free radical induced changes by the cardiac, which has a special propensity on the cardiac muscles, because it is topoisomerase 2 inhibitor. It's present more on the cardiac muscles also. Next slide. Next slide, ma'am. So coming to the gemcitabine cisplatin combination, gemcitabine is 1250 mg per meter squared per day on day 1 and day 8. And cisplatin, it is 70 mg per meter squared on day 1. Or if it is a split dose, it can be given as 35 mg per meter squared on day 1 or 2 or day 1 and 8. Basically, these drugs are covered already, so I am not going into the details and description of these drugs. Gemcitabine is given in the standard 250 ml NS over 30 minutes, and cisplatin as per the high dose cisplatin protocol. And this is repeated every 21 days and for a maximum number of 6 cycles. Next slide. There is emerging role of adjuvant immunotherapy of nivolumab also, as per the Checkmate 274. Next slide. Next slide. Moving on to the metastatic bladder cancer. Bladder cancer also involves the role of DD-MVAC or the cisgem combination. And if they are already exposed to the platinum, we have the subsequent immunotherapy role. And so all the immunotherapy have been tried. N number of trials have been done in bladder carcinoma metastatic setting. And the first one to talk about is the avelumab. So avelumab can be used as a single agent monotherapy in this metastatic setting, or it is given after the chemotherapy as a maintenance therapy after the cisplatin gemcitabine, once they have achieved a response, partial or complete response, for maintaining the disease response. The other immunotherapies are pembrolizumab, nivolumab, avelumab, and natazolizumab. They have been tried in this metastatic bladder cancer. Pembrolizumab and nivolumab are in the category 1 recommendation, and which includes avelumab also. And in the subsequent line of therapy, the other chemotherapy regimens which are used are the gemcitabine, paclitaxel, docetaxel, and ifosfamide, either as a doublet or a single agent, depending upon the patient's performance status. And the FGFR3 inhibitor, which is the erdafitinib, and the antibody drug conjugate, which is the enfortumab vedotin. And in third line therapy, beyond more than 3 lines of therapy, sacituzumab govitecan is also used. Next slide. So as I've already mentioned, so we have to see the platinum eligibility, and if they are platinum eligible, we prefer to use the chemotherapy. And in subsequent line of therapy, that is in the second line, if there is a progressive disease, we can consider pembrolizumab. If GFR3 mutation is present, we can consider erdafitinib. And in the subsequent line, after response assessment, if they are needed in the later line of therapy, chemotherapy, which includes the paclitaxel, docetaxel, can be used, or And other drugs like enfortumab vedotin, sacituzumab govitecan can be used. If they are platinum ineligible patient, we have to look for the PDL1 concentration, PDL1 reporting, and accordingly we use the immunotherapy. Next slide. So this is the same which I've already mentioned, platinum eligibility and ineligibility and the drugs used in these conditions as per the NCCN. Next slide. Next slide. So pembrolizumab is recommended in the first line setting as a category 1 recommendation. And as already mentioned, the subsequent drugs are also used. We'll see the other drugs in detail. Next slide. Next slide. So the dose of various immunotherapy is pembrolizumab 200 mg IV 3 weekly as per the Keynote 361 trial with chemo, or as a monotherapy as per the Keynote 045. Nivolumab is 240 mg every 2 weekly as per the Checkmate 275. And avelumab maintenance, it is 10 mg per kg every 3 weeks. And atezolizumab has also been used as in a dosage of 1200 mg every 3 weekly as per the IM Vigor 211. Next slide. Next slide. Sir, as the immunotherapy's mechanism of action has been discussed in detail during the previous sessions, for the want of time, I'm skipping these slides also. Next slide. So we know that immunotherapy can affect any part of the body, and because of its immune-mediated reactions. So the important reactions which can occur are the pneumonitis, hepatitis, and skin rashes. And with concern to the bone marrow, it is anemia, thrombocytopenia, neutropenia, and encephalitis can occur, hypophysitis can occur, myocarditis can occur, and colitis can occur. To give a special mention, the first toxicity which occurs is either the colitis or the skin reactions, and other reactions of any part of the body can occur after a prolonged period of exposure of the drug. So the first toxicity is manifest is the skin rashes or the colitis, which occurs immediately within a few weeks of the exposure of the drug. Next slide. Next slide, ma'am. So basically, what has to be done after the immune-related toxicities, we have to have a basic idea. So if it is occurring, so the earlier to occur is the fatigue and the dermatological toxicities, as I've already mentioned. And after the dose 1 to 3 is the gastrointestinal toxicities. Beyond the dose 3, it is the hepatitis and the endocrinopathies and other immune-mediated reactions like uveitis, pancreatitis, neuropathies, pneumonitis, and myocarditis may occur subsequently or very rarely. Next slide. So what we have to do in case of any type of immune-mediated adverse reaction. So if we have to grade the toxicity first, we have to first put a leading question to the patients every time. We have to have a broad idea about all these toxicities, since it can affect anywhere. So ask the leading question, find out the toxicities from the patient, because the patient might not be aware of those things and they might take it as a minor symptom only. So ask the patient, that is very important, and grade the toxicities based upon the grading. It is grade 1. We can continue the immunotherapy with symptomatic management with a frequent monitoring. And for the grade 2 toxicities, we can delay the immunotherapy for 1 week or 2 and treatment of the symptoms symptomatically, and resume immunotherapy when the symptoms improve to grade 1. We can consider glucocorticoids at the dose of 0.1 to 1 mg per kg. And if it is worsening to grade 3 or grade 4, we can discontinue the immunotherapy at that point of time. So if it is grade 3 to grade 4, discontinue the immunotherapy except in patients with skin or endocrine toxicities. And we have to initiate glucocorticoids at the dose of 1 to 2 mg per kg per day. And we have to keep them under hospitalization to closely watch the patient. with corticosteroids. So after starting the immunotherapy, it is very mandatory that we closely follow up the toxicities. Next slide, please. So avelumab, which has not been discussed previously, so that drug alone I'm going in detail. So avelumab is used in combination with axitinib in the first-line treatment of metastatic RCC. And here in urothelial cancer, as already mentioned, it is 800 mg every 2 weeks. And in renal cell carcinoma, it is used with axitinib. So subsequently, we'll be talking about RCC also. So how to administer this drug? Withdraw the required volume of avelumab from the vials and inject into a 250 ml infusion bag containing either normal saline and administer the diluted solution over 60 minutes through an intravenous line containing a sterile, non-pyrogenic, low-protein binding in filter. Do not co-administer with any other drugs through the same IV line. Next slide, please. The next is the erdafitinib. So this is the FGFR3 inhibitor. The important thing is that it is used in subsequent second-line therapy when it has progressed with a platinum-containing therapy or previously a immunotherapy or the patient has been exposed. The important thing is that they have to confirm the presence of FGFR3 genetic alteration in the tumor. So only if that is present, we can have the option of exposing the patient to this drug. So this is a kinase inhibitor in those who have progressed on or after at least one line of therapy. The dose is 8 mg orally once daily with the dose increased to 9 mg if the criteria are met. It has to be swallowed as a whole with or without the food. So food doesn't have any influence on this drug. The important classic side effect of this drug is the hyperphosphatemia and the central serous retinopathy. The other side effects which can occur are the stomatitis, diarrhea, increased creatinine, increased liver enzymes, decreased sodium, fatigue, dry mouth, dry skin, decreased appetite, and constipation, increased calcium. As usual with any other kinase inhibitor, it is a HFS syndrome also, increased potassium, alopecia. These are all the other side effects, but the classic side effect peculiar to this drug is the hyperphosphatemia and the central serous retinopathy. So we have to keep a check on the levels of the phosphate and manage accordingly. Next slide. Next comes the drug. This is the enfortumab vedotin ADC. The recommended, it is a Nectin-4 directed antibody and microtubule inhibitor conjugate indicated for the treatment of metastatic urothelial cancers. And the dose is 1.25 mg per kg given as an IV infusion over 30 minutes on day 1, 8, and 15 of a 28-day cycle till disease progression or unacceptable toxicity. So the next one is the sacituzumab govitecan, and the most common side effects of this drug is the hyperglycemia, peripheral neuropathy, ocular disorders, and it is a vesicle, so it has appropriate and appropriate care should be taken, and skin reactions can also occur. The next slide, please. So this comes the sacituzumab govitecan. It is used beyond 2 to 3 lines of therapy. It is a TROP2 directed antibody and topoisomerase inhibitor conjugate. The boxed warning is the black box warning given by for the drug is the severe neutropenia and severe diarrhea. Because the drug which is there is the SN138, similar to the irinotecan. So the other common side effects are the nausea and vomiting, decreased creatinine clearance, increased alkaline phosphatase, decreased magnesium, decreased potassium, and decreased sodium. And the recommended dose is 10 mg per kg once weekly on day 1 or 8 of a continuous 21-day cycle, which is given till progression or unacceptable toxicity. So special concern should be given. What should be given for the neutropenia and diarrhea. There is a black box warning given for this drug. Next slide, please. So moving on to metastatic renal cell carcinomas. So in a metastatic renal cell carcinoma, there is a number of agents which has been used, which involves the TKAs and the immunotherapy and the combination of both the drugs. Next slide. Basically, there is an interplay of all this hypoxic factor and the VEGF factor in the renal cell carcinoma. So both has to be taken care simultaneously, and that is how the combination of immunotherapy and the TKs came into evolution. So when there's overgrowth of the VEGF, the suppression of the T cell trafficking and infiltration occurs, which is taken care by the tyrosine kinase inhibitors and the immune checkpoint inhibitors. And there also increase in the hypoxic because the basic pathogenesis of the renal cell carcinoma is that there's hypoxic HIF2 alpha overexpression. And these two drugs are very eminent in acting against the VEGF and this pathway. Next slide. So in the stage 4 metastatic setting, we have to first stratify the patients into favorable, intermediate, and poor risk. And accordingly, we have the various combination of drugs. So in the favorable risk group, it is the category 1 recommendation is given for the axitinib and pembrolizumab, cabozantinib and the nivolumab, lenvatinib with pembrolizumab. In the poor and the intermediate risk, it is axitinib with pembrolizumab, cabozantinib with nivolumab, and ipilimumab with nivolumab, lenvatinib with pembrolizumab, and cabozantinib. In the subsequent line of therapies, whichever drug has not been exposed can be given subsequently. If immunotherapy has been exposed, subsequently we can address the patient with the TKAs. Next slide. So moving on to the drug ipilimumab, it is a human cytotoxic T lymphocyte antigen, that is CTLA4 blocking antibody in advanced renal cell carcinoma. So how it is administered? It is diluted with a normal saline injection to prepare a diluted solution with a final concentration ranging from 1 mg per ml to 2 mg per ml. So any of these drugs, be it immunotherapy or chemotherapy, care should be taken while mixing these drugs. The thing is that while injecting the drug or mixing the drug with the diluent, special care should be taken, and the injection, while during injection, it should be injected along the walls of the bottle only, so that we can avoid the foaming, and we have to slowly mix the diluted solution by gentle inversion, and harsh procedure should not be used. This procedure care should be taken for mostly all the drugs to avoid foaming and frothing. So this basically is a 90-minute infusion, and the dose is along with nivolumab, which is 3 mg per kg, followed by ipilimumab at a dose of 1 mg per kg on the same day, which is given every 3 weeks for 4 doses. After that, after this combination, that is doublet therapy, nivolumab 240 mg is given as a subsequent line of immunotherapy maintenance. Initially, nivolumab with ipilimumab used for 4 doses, and subsequently nivolumab is continued. So ipilimumab, as it is a CTLA4 blocking antibody, the toxicity is similar to any kind of immune-mediated reactions. Special point is that in nivolumab with ipilimumab, hepatitis is more common, and special care and monitoring for this hepatitis should be taken. Next slide. So moving on to the TKAs in RCC, they are all the multi-targeted tyrosine kinase inhibitors, which are the sunitinib, sorafenib, pazopanib, axitinib, lenvatinib, and cabozantinib. So we have the first generation and the second generation TKAs. How they are different is that the subsequent subsequent generation of TKAs have a multi-targeted action. They additional action on c-KIT, FGFR are all more pronounced with the newer TKAs. So initially sorafenib for use. Subsequently, when the second generation TKAs are proven to be beneficial than the sorafenib, now sorafenib is used only in the subsequent line of therapy. Next slide, please. So sorafenib, it inhibits multiple intracellular CRAF, and KIT mutation, KIT receptors, FGF, VEGF1 and 2, and PDGFR beta. It is mainly utilized as a later line therapy for the advanced renal cell carcinoma, and dose is 400 mg twice daily till disease progression or unacceptable toxicity. It is recommended that sorafenib should be administered without food. The adverse events is that it can result in hypertension, heart failure, QTC prolongation, hemorrhage, perforation, anemia, thrombocytopenia, hepatic enzymes and elevation, and HFS. So we have to definitely know these side effects to monitor these patients. And when they are giving a lead complaint, we should also follow them up for this ECG monitoring should be done. And in any post-operative patient, or if the patient is going to be taken up for some other surgery, we have to have this hemorrhage perforation at the back of the mind, and we have to give adequate interval between the TKAs and the surgery also. Next slide, please. So most of the TKAs and most of the immunotherapies have most of the toxicity profile in common, except for a few. So here, sorafenib, when the creatinine clearance is low, we need to modify the dose. And in hepatic impairment, there's no dose adjustment required. Temporarily withhold sorafenib for at least 10 days prior to the elective surgery. Do not administer sorafenib for at least 2 weeks following a major surgery or adequate wound healing. So coming to the hepatic enzyme derangement, if it is elevated more than 3 times, it is better to permanently discontinue. Sorry, here it's a typing mistake, like hepatic enzymes alteration, we have to permanently discontinue. And regarding the dose reduction in case of any toxicity, it can be reduced to 400 mg once daily and subsequently to 200 mg once daily. But in a routine clinical practice, hardly most of the patients don't tolerate this standard dose of 400 mg twice daily. I don't know, it may vary from institute to institute as my personal thing. So if anybody has any difference of opinion about that, please tell. And next slide. Regarding the sunitinib, it comes as the capsule strength of 12.5 mg, 25 mg, and 50 mg. And it is also a multikinase inhibitor acting against, additionally, it also acts on the FLT3 tyrosine kinase and the colony stimulating factor receptor and the RET receptor, in addition to the sorafenib. Here, regarding the TKAs, only sorafenib has a food effect of food on its bioavailability. Here, sunitinib does not have any effect on the bioavailability of this drug. So this administration is basically 4 weeks on and 2 weeks off. It is the standard schedule. And based upon the toxicity and the patient tolerance, the treatment schedules have been tailored in various institutes according to the convenience also, which is actually not a standard, but it has been done. Routine schedule as per the trials are 4 weeks on and 2 weeks off. Next slide. Next slide, ma'am. The most common adverse events as for the other TKs is the asthenia, fever, diarrhea, mucositis, hypertension, peripheral edema, HFS, skin discoloration or hair changes, and sunitinib here also it should be interrupted if there is any grade 3 or 4 hepatic events. We have to give a special concern and monitoring about the cardiac toxicity, which is the left ejection fraction. If it is declining or any prolongation of the QT interval is there, it has to be picked up early and intervene in between. And hypothyroidism can occur. Hemorrhagic events, including the tumor-related hemorrhage, have occurred. Next slide, please. Regarding cabozantinib, the dose is 60 mg orally once daily. 40 mg once daily is given in combination with nivolumab 240 milligram every 2 weeks, or 480 mg every 4 weeks. And this is a multikinase inhibitor, and because of this extensive action on multiple kinases, the Side effects are also more pronounced with the cabozantinib than compared to the other thing. HFS is more pronounced than the other TKAs. And here it is administered at least 1 hour before or at least 2 hours after eating. And next slide. The side effects of cabozantinib more or less overlaps with the similar other TKAs also. So that is the diarrhea, fatigue, hypertension, HFS, hypothyroidism, musculoskeletal pain, impaired wound healing, hepatotoxicity, more or like other TKAs. And as I told earlier, since it has a multiple actions on various multi kinases, the side effect profile is also increased with cabozantinib. Especially we see in clinical practice, HFS is more pronounced with cabozantinib. Next slide, please. Coming to the axitinib, it is a selective second generation tyrosine kinase inhibitor, and it is available as 1 and 5 mg. And it is followed, the tablet is swallowed as a whole with a full glass of water. It may be administered with or without food. And dose adjustments are needed for the lower creatinine clearance and are not needed. And if proteinuria is occurring as a result of a toxicity of axitinib, at that point in time, you need to intervene and withhold the drug. Next slide, please. Next slide, please. One more thing to mention about axitinib is that it is used in combination with avelumab. It is used in combination with pembrolizumab. And it is mentioned as a category 1 recommendation for RCC in most of the risk that is favorable and intermediate and poor risk. One more thing to especially mention here that due to the short half-life of axitinib, the plasma concentration rapidly decreases following the treatment interruption, which supports therapy management of the IO and TKA combination. So, when a number of toxicity are anticipated or occurring during a combination of TKA and IO therapy, here when the axitinib has a shorter half-life, the prolongation of the toxicity is also limited. So that is a peculiar difference between the other drugs and the axitinib. Next slide, please. So moving on to the drugs in the prostate cancer. And one more thing is that non-metastatic renal cell carcinoma also, the use of immunotherapy has been recommended. And since that is the same immunotherapy, I have not described that specifically here and not repeated here. And so moving on to the drugs in the prostate cancer, basically the docetaxel, abiraterone, enzalutamide, darolutamide, apalutamide, and cabazitaxel. Next slide, please. So abiraterone selectively and irreversibly inhibits the CYP1717 alpha hydroxylase and C1720 ligase, an enzyme required for androgen biosynthesis, which is expressed in the testicular, adrenal, and the prostatic tumor tissues. So in between, it is blocking the stepwise process in the production of the testosterone. So there is an interruption in the glucocorticoid. So what happens is that the glucocorticoid deficiency symptoms can manifest when the patients are given abiraterone. So that is why a prednisolone combination is always given with abiraterone drug. So this inhibits the formation of testosterone precursors DHEA and androstenedione. Tablets are available as 250 mg and 500 mg. Abiraterone acetate is available in some countries as a different tablet formulation also, which is not interchangeable. Regarding the dose of abiraterone, it is 1000 mg administered orally once daily in combination with prednisolone 5 mg. It is taken twice daily. And due to the cost issues and its interaction with the food, abiraterone has a special mention about that since its bioavailability varies with the food and especially a fatty meal. So based on that, since its bioavailability increases with the fatty meal, there were studies which are conducted to consider lower of albuterol when taken with a fatty meat. When taken with a fatty meat. So this phase 2 study suggests 250 mg once daily administered with or within 30 minutes of a low-fat breakfast, which is non-inferior to the standard dose. And prostate-specific antigen and progression-free survival results were similar between the two arms, although higher drugs were reported with the standard dose. So this decreases the patient financial burden and improves adherence for those in research post sitting. Next slide. Basically, the side effects for these drugs are the cardiovascular side effects, which, where edema can occur, hypertension can occur, metabolic side effects like hot flashes, hyperglycemia, hypernatremia, hypertriglyceridemia, hypokalemia. This hypokalemia can occur as a result of when the downstream pathway has been inhibited by this drug. Symptoms of insufficiency can occur. Regarding the gastrointestinal, it is constipation, diarrhea, and occurrence of frequent urinary tract infection can occur. Hematological and oncological side effects like lymphocytopenia can occur. Increased serum enzymes and bilirubin can occur. Regarding the respiratory system, frequent occurrence of upper respiratory infections can occur. And regarding the nervous system, the patient complains of severe arthralgia, fatigue, is more commonly told by the patient. And because of all these things, there is history of falls also, which has to be taken care. Moreover, the patient will be already metastatic with a number of bone mets. And in addition to that, when we are giving a drug which can cause a higher instance of falls, we have to be very careful. And this is morely also expressed by other drugs which are used in the prostate cancer. Next slide.
Dr. Chandralekha, I would request you to conclude in next few minutes in the interest of time.
Sorry? Yeah.
I would request you to conclude in next few minutes in the interest of time.
Sure.
So, thank you.
Next slide. Ma'am, next slide. So the next drug is the enzalutamide, which is 160 mg per oral daily. The available doses are 40 and 160 milligram. It competitively inhibits the androgen binding to the androgen receptors and inhibit androgen receptor nuclear translocation and interaction with the DNA. Next slide. So the most common side effects are the arthralgia, back pain, hot flashes, and history of falls. Seizures is peculiarly seen with enzalutamide since it crosses the blood-brain barrier. CNS toxicity is also more pronounced. And the other drugs are the daralutamide and the apalutamide, which is used in various settings in the CRPC and the non-metastatic CRPCs. And these have a similar kind of, next slide. The daralutamide, which is dose is 600 mg twice daily, and it is available as 300 mg. Next slide, pa. Next slide. The apalutamide, which is used in the metastatic castrate-sensitive prostate cancer and non-metastatic castrate-resistant prostate cancer. The dose is 240 mg, administered orally once daily. And the side effects of these drugs are more or less similar. And special mention about the cardiovascular fatigue, that is the neuromuscular side effects are more pronounced in these drugs. So we have to monitor for this GI side effects and the cardiovascular side effects, especially the QT prolongation, everything has to be given concern. And frequent monitoring of the patient with ECG and echo is mandatory for these drugs. And there is history of falls in these patients who are taking these oral drugs, and special mention and care should be given to the caretakers. Instruction to be cautioned is very important. Next slide. Cabazitaxel is a microtubule inhibitor used in subsequent line of therapies where they have been previously used to exposed to the docetaxel. The dose is 25 mg per meter squared every 3 weeks as in 1 hour infusion in combination with oral prednisolone. The next slide. Cabazitaxel has a higher incidence of febrile neutropenia, so care should be taken upon that. Next slide. The last of the day is the testicular tumors. So we know the common regimens used are the BEP regimens, and in subsequent lines of, in case of recurrence or the patient has a high mediastinal burden of tumor, we can use this VIP and the TIP regimens. So I've just mentioned about the BEP regimen. Next slide. So here we have to adequately pre-medicate the patient, and care should be taken upon the hydration of this patient, since this pattern is given for day 1 to day 5, and it is highly emetic, highly neutropenic, has a propensity for neutropenia. So care should be taken. And one more thing is that the bleomycin, one important notorious drug, is there in this combination. So care should be taken upon the skin toxicity and the lung toxicity, which is much more of concern for the patients with testicular tumors, especially who are young. So bleomycin, the dose is 30 units, given in a 50 ml IV as 50 ml NS for over 10 minutes. And so this is the schedule which is given every 21 days. Next slide. Next slide. So word of mention about the bleomycin, it is a lyophilized powder, and the most common is the dermatological toxicity and the pulmonary toxicity. Hypersensitivity can also occur. Next slide. So this is the typical flagellate rashes which are seen following bleomycin. We have to closely watch the patient, with the patient, and see for these reactions. This occurs usually because of the lack of bleomycin hydrolase in the skin and the lung. This occurs because of the direct DNA damage through the generation of reactive oxygen species. Next slide. Next slide. So as for the bleomycin, we have to have a baseline pulmonary function test examined, and the DLCO should be initially examined at before starting the drug. And only if it is normal, we can proceed with the drug. And DLCO should also be monitored in between the cycles. And if any decrease in the DLCO is there, interruption of the bleomycin, stoppage of the bleomycin should be strongly considered. The pulmonary toxicity can be in the form of pneumonitis, which can occur or progress to pulmonary fibrosis. And the risk is higher in elderly patients or in patients who are receiving more than 40 units in the total lifetime, and those who have a history of prior radiation, or those who have a prior COPD diseases. Next slide. Next slide. So basically, all the drugs, be it any chemotherapy drug, has proper efficiency rate and also a toxicity profile. So it is very important that we maintain the efficacy and the safety, and maintain a balance for the patient, including the financial constraints also. Thank you. Thank you. Thank you, everyone. Thank you, everyone, for sparing your time on a Sunday. And I especially thank Dr. Hemanth, sir, for guiding through the session.
Thank you, Dr. Chandralekha. I think it was very vast topic to cover in a short span. I think you
Yes, sir.
covered most of the aspects. It's a varied actually in genitourinary system where we have something which not changed for almost 4 decades, that is testicular tumors. And we have something in like RCC every year it changes something. So, but anyway, covered well. Any questions, or shall we go ahead with the exams?
So far there are no questions in Q&A box, so I think we can proceed for the Viva session.
So I would take this opportunity to invite Dr. Amit Joshi, sir. He's a professor and head in Department of Medical Oncology at ACTRAC. Sir would be taking exam of candidate. We have candidate, no, right? Dr. Anupama John. Anupama John.
Yes, sir.
Yeah. So she's a student from Tata Memorial. I think if anything is there, we'll ask. Otherwise, Dr. Amit, sir, you can go ahead.
Vinayak, what will there will be some slides for the questions?
Yes, yes. So basically, I think what we are looking is how we're going to integrate those drugs into the clinical practice. I think that's the rationale. Go ahead, sir. No issue. If anything is there, I also can intervene in between questions.
So I think she will lead the cases, then I will ask the questions. So this is the case. So it's a 75-year-old lady presented with the hematuria. Ultrasound shows a growth in the bladder, and with the urologist opinion, patient underwent the TURBT. Next slide. So, Anupa, how you will want to proceed with the histopathology report, and what are the components in the histopathology report you want to see, and further treatment planning for this patient?
So basically, now that the urologist has gone ahead with a TURBT, first of all, I would like to get the histopathology report. I would like to know if the muscle sections have been involved in the have been included in the specimen that has been sampled. I would like to know whether the stage of the disease, whether it is a muscle involving bladder tumor or it's a NMIBC. Accordingly, I will decide the further plan for this patient.
Any other additional information? So the histopathology report says the urothelial carcinoma. So do you want to know other what we call as a variant histology? So
Yes, definitely. Other variant histopathologies also I would like to
so
know in
what are
this.
the different variant histopathology where the treatment is going to change as per the, suppose the histopathology is urothelial carcinoma with plasmacytoid variant of 20% versus the urothelial carcinoma with the 20% neuroendocrine component. So will your management change in these two scenarios?
Yes, so neuroendocrine variant definitely would be a more aggressive histopathology. I would definitely require a systemic staging. I would definitely need to reconfirm, even if it is a NMIBC, whether it is a muscle involving disease in case of a neuroendocrine tumor. The prognosis will be decided by the neuroendocrine component in this scenario.
What is the other variant which may influence the treatment pattern?
Sarcomatoid variant.
How it will change?
So there is some data of role of immunotherapy in, but this is mostly extrapolated data from RCC. So
the other one is the micropapillary variant. So sometimes with some literature says that patient presenting with the micropapillary variant may have a aggressive course. So some institute follows the T1 tumor with the micropapillary can proceed for upfront cystectomy.
yes.
So these are the two variants. Other rest urothelial, whether the plasmacytoid or squamous and all, mostly management, although prognosis may differ, but the management is same. So management is
Yes.
changes on the two only, the neuroendocrine component and the probably in the micropapillary variant. So suppose the histopathology doesn't say, or it's an NMIBC. So what are other information you want to know for the treatment planning?
So basically, I would like to know the stage and the grade of the tumor, the size of the mass that was
How the size
removed.
will decide? Is there
If
any?
it's less than 3, if it is mainly a papillary growth less than 3
Yes.
centimeter.
Yeah, so it will come into the category of less than 3 centimeter.
Low risk.
Yes. So what the neurosurgeon do whenever they do a TURBT? What is the additional procedure they do immediately after that?
So they would probably do a gemcitabine installation at that immediately post-op.
Gemcitabine.
So gemcitabine, either gemcitabine or mitomycin C, in case it's a low.
So
Low
I
grade.
think until
A
proved,
single.
so mostly it's a mitomycin C.
C.
Mostly the gemcitabine is mostly where there is a BCG unavailability or some. So first treatment is the
Mitomycin C.
mitomycin C, and then when the final HPR come. So how so suppose the histopathology shows that it's a T3 tumor. So what additional investigation do you want to do before proceeding further?
So I would like to know the nodal status in case it's a T3 tumor.
Yes, so imaging is needed. So what sort of imaging you do in these patients?
Like MRI pelvis, abdomen and pelvis would be most
Why?
beneficial.
Why
So
you want to do MRI pelvis? It's already say
the plane. Okay, no, in that case, the CT abdomen pelvis, sir.
yeah. So MRI mostly is not when there is a doubt regarding the local staging and
Local
then
stage.
and so still the MRI role of MRI is still evolving. There is one trial known as bladder path trial that has just published the data of the role of MRI. So the purpose of MRI is to can we avoid the TURBT in this scenario to locally stage the disease. So the purpose of the local MRI is to locally stage the disease.
Stage the
That can we
disease.
avoid the TURBT that till this practice, so still it's in the has not taken into the practice. So still the CCT abdomen pelvis with thorax will be the choice with the choice. Is there any incremental value of doing PET in this case?
No.
Yes. So as such, PET is not needed. So what are the other conditions in the whole body where you want to do a PET CCT for staging purpose? Not Euro, overall in all the organs where you want to do a PET CCT before starting the initial treatment.
So in lung, we would definitely there's a advantage of PET CT to a CT.
What is the incremental value of doing a PET?
I'm not really sure about the numbers, sir.
So I think so. What we call as a term as futile thoracotomy. So the literature varies. So close to 15 to 20% patient may be upstage by
With
doing a PET CT, and futile the surgery can be avoided. So one is the lung. What is the other place where the PET has a definite, apart from the hematological malignancies? One is the lung, and where is the second organ where you need to do a PET CT before planning local treatment? In the thoracic, what is the other organ?
Esophagus.
Yes, so the esophagus. So these are the two organ where there is a and in other sarcoma like rhabdomyosarcoma, Ewing sarcoma, definitely there is a role of doing a PET CT for staging these. So coming back to this case, can you go for next slide? Yeah, so it's a 4 centimeter tumor, high grade, and muscular dystrophy are not involved. So what will be your treatment plan for this patient?
So this patient, because it's a high grade involvement, it will go into the high risk category, and the size of the tumor is more than 4 centimeter. So for this patient, ideally she should receive intravesical BCG installations.
So if you whenever in the exam the examiner asks for the treatment, then it's always best to tell the treatment planning, the BCG so definitely you will not get this type of case in the exam, but like a breast cancer. So if you want to examiner wants the treatment protocol or management protocol, then start from the, I will like to start with the neoadjuvant paclitaxel at the dosage of this with trastuzumab with how many cycles. Then I will evaluate the patient after 2 or 3 cycle, and then complete the neoadjuvant, and we'll go for a local surgery, and then we'll continue. So with, if you can tell with the doses, that is very well. Otherwise, just don't tell the drug. So it's a single agent paclitaxel. No, tell the doses and the duration, that will complete the treatment. And the examiner understands that the student knows the management strategy and the so tell full treatment protocol, which includes the surgery and the radiation also.
So we will be giving this patient intravesicular BCG installations. This will be done for the first 6 weeks. It will be weekly for up to 6 doses. Followed by this, it will be done at every 3 monthly. It will be given for 3 weeks each. Since this is a high risk disease, ideally the patient should receive it up to a duration of 3 years.
So suppose the patient develops the what we call as a BCG intolerance and is not able to complete the treatment protocol. or patient develops a BCG refractoriness, that the even after taking a BCG cystoscopy again, so after a 6 month again shows a lesion, and then again TURBT version which is still non-muscle invasive, but so what we call it a BCG refractoriness. So what will be the treatment choice, and what are the other indication for that treatment option in that scenario? Some systemic treatment option in that scenario. So
if
BCG refractory or
refractoriness-
BCG, yeah.
If the patient is BCG refractory, then the patient has to be systemically managed.
So what is the standard management for this patient? And what are the alternative options that we want to?
So the alternative options in this case would be, you can use gemcitabine actually.
Intravesical. Any other
Intravesical.
systemic option? Any other better systemic option? Or but not better, but other systemic option?
So the other option, the systemic option, otherwise, that in this situation, you can, if the patient is BCG refractory, if the lesion is recurrent, persistent, then this patient can be considered for radical cystectomy with adjuvant immunotherapy as per Checkmate 565.
Yeah, so the standard treatment for this type of patient is preferably a radical cystectomy, but those patients who are not willing or keen for a radical cystectomy, the other alternative option is to consideration for a pembrolizumab intravenous.
Adjuvant for.
So it's intravenous, not the intravesical. So the data is evolving further, but till this point of time, and the end point of that study was cystectomy free survival. And I think the updated data was presented few days back, and it's close to, I think, after the end of the 2 year, 40% patient, that number I'm not still sure, 30 or 40% were able to retain their bladder in patients who receive. So that is one of the systemic option from them for that period. Okay, next slide, please. So I think this is what we were discussing, the low risk, intermediate risk, and high risk, and then they manage accordingly. So just one last question in the non-muscle invasive. So what is the characteristic histopatho or the abnormality or the mutation seen in the early bladder tumor compared to the advanced tumor, which has some therapeutic implication?
FGFR3.
Yes, so 70 to 80% of the low-grade tumor have a FGFR3 alteration. So it may be fusion, it may be mutation, and it is therapeutically. So the field of this low-grade papillary tumor is rapidly evolving, and there are various intravesical FGFR3 inhibitor, including the aldafatinib, the drug delivery system is rapidly evolving. The only additional is the thing which has come up apart from this intravesical drug delivery is the gene therapy. So what is the latest development in that, in this scenario? Any name some of the compound which is being used in this scenario? That may be sometime a theory question in terms of the recent development. So it is one of the places where the adenoviral vector therapy has shown. So it's very complicated name. Yes, I think someone has written the fibroadenovac. So that is one additional which has, and there is another after that. There is second generation of adenoviral vector therapy where the viral vector will be delivered intravesically, and that acts locally in preventing the recurring disease. These are the two new development: the intravesical FGFR3 therapies and the intravesical adenoviral vector therapy. These are two new things have come up in that. So we'll go to the next slide. So I think these are the discussion what we have done so far. So for our understanding, after TURBT, you have to look two things: whether there is a muscle present or not, detrusor muscle present or not. If detrusor muscle is present, then it is involved or not. So sometimes you get a biopsy specimen, TURBT specimen from outside. where they have said that they will not comment on that whether the detrusor is included in the specimen or not. So then you have to go for a repeat TURBT. So without a histopathological examination clearly mentioning that detrusor is included and involved or not involved. So if there is no comment on the detrusor, mostly we want to go for a repeat TURBT. Next, please. So I think so. So the second question, which will be quickly take, that for muscle invasive disease, how you will proceed for a 55-year male presented with a muscle invasive bladder cancer. It's a T3N1 disease. So how you will proceed? Then the discussion will be of that T3N1, M0 with a serum creatinine of 1.4.
So basically, this patient has an elevated serum creatinine. I would definitely require. So if he's an otherwise fit male who is cisplatin eligible, then I would definitely consider the option of perioperative DDMAC neoadjuvant.
So with say creatinine of 1.6, not 1. So with the growth involving the VU junction, which is leading to say moderate hydronephrosis, which we commonly see in the day-to-day setting.
So in this case, he would probably have to go for an upfront radical cystectomy first, followed by adjuvant chemotherapy.
So
because
patient
is
fit and his creatinine is because of the obstructive of because of the hydronephrosis, because of that mass lesion.
So another option would be to relieve the obstructive uropathy, and then by like he'll probably require a DJ stenting to be done if it is feasible, and then he would require.
So the message is that if the creatinine clearance is deranged because of some obstructive component, and you can relieve the obstruction by doing a PCN, and then still an attempt should be done in a younger, fitter patient, where you know that this is a reversible phenomena, and the renal function are deranged because of the obstructive component. Then it's always better to go for a, although giving chemotherapy in this scenario is not the it's challenging, but still in a young fit patient we should try to go for a PCN, and then because it's a chemo responsive tumor, so sometime after first cycle of chemotherapy you may get some relief in the obstructive component, and the hydronephrosis may come down. You may remove the PCN if there is a significant movement, or you can consider for a DJ stenting from that aspect. So attempt should be made to that, giving the cisplatin based chemotherapy. So patient, suppose his creatinine clearance is coming to be 52. So which chemotherapy regimen, what method you will go with that? What will be your plan?
It basically depends on how fit the patient is primarily.
If otherwise fit, cardiac function is normal,
then dose dense MAC can be considered.
Even in patient with a creatinine clearance of 52, you will be comfortable.
No. So if I can relieve the obstruction, if I can improve the creatinine, yes. Otherwise, Gemcis would be what I would ideally consider for him. I might split the dose of cisplatin.
Yes, so that we want to set, that we want a discussion that in patients who are otherwise fit for the chemotherapy but just unfit because of the creatinine, you may consider. So what is that regime? How what is the dosage we use, and what is the level of evidence with that? Next slide, please. Next slide, please. Okay, so I think there's something. What is this drug? What is the peculiarity in this slide? Can you see the color?
Yes.
What is the color?
It's bluish.
Yeah, so is it a characteristic? So name some of the other drugs which are colorful.
So anthracyclines are reddish. Methotrexate is yellow.
I think these are the two which anyone can have, and these are the three which we. So mitomycin, which group of the drug it belongs to that?
Antitumor.
Sorry.
Antitumor antibiotic.
Yeah, and how it works?
So basically, it affects the topoisomerase 2 inhibition.
Mitomycin. I have to check.
No,
Sometimes the student answers that confidently that even our confidence gets shaky. Am I thinking in the right way or wrong way? I don't think so that it's a topoisomerase. I think it's
No,
a alkylator directly damaging the that what I think check that
yes, sir.
and name one peculiar toxicity of giving when we give intravenous. What are the two specific side effects which we have to yeah.
Uh,
It's a vesican
extravasation.
drug that we have to remember that.
Extravasation.
Yeah, extravasation. So that is one thing. What are the other chemotherapy regime where this drug is being used in IV?
In rectum. Yeah, anal canal.
Rectum
Anal
is.
canal. Anal canal.
Yeah, I don't do
No. Anal
GI,
canal.
then you can't answer me I know. So it's the anal canal.
Anal canal.
Yeah, and the other rare indication where that can be used theoretically, which we use very rarely. Sometimes in the bladder concurrent, there is some data, but we generally don't use too much. But the mitomycin C is one of the regime which is being used in the anal canal CTRT. Okay, next slide, please. Vinayak, if you can ask, you can also get involved in asking question, or do I have to only ask the question?
Well, we can join, sir. Yeah, I think
that will be better. So I think because everyone will have some other experiences, so we can quickly finish by that. I think you can take over and ask few questions in this situation.
Sir, I also request Dr. Hemanth Kumar sir to join for this session, sir.
Yeah, I think it's best that I think Dr. Purvis is also there. I think he can also ask few questions.
I request Purvish Parik sir to join too, sir. It would be really very insightful for the students, and it would be really it's very lucky that we have so many experts today in our sessions. Sir. Thank you.
so. I'll start with a few questions. So in muscle invasive, how do you see? Have you seen any report which they say muscle is not is muscle involved or not? How you know it in the report? What they'll write?
So then they will write that sections submitted include the muscle layer, muscularis propria layer, and they are involved or not. They would specify.
Invasion is there or not? So why does it matters? What is the prognosis of a stage 4 disease compared to if you stage wise? Like if you take a bladder, stage wise, how the prognosis is there? What are the options for low grade CA bladder? What do you do?
Based on whether it's MIBC or NMIBC.
So non-MIBC, what do you do?
So the options include low grade include a single dose of mitomycin C or gemcitabine or epirubicin.
Yeah. So you don't even operate, correct?
No.
So
No, you do a TRBT and then you
don't remove the whole organ, right?
No.
Yeah. So that is how the prognosis is there. Even without that surgery, outcomes are so good. If you go for MBC, metastatic disease, expect survival is untreated. How much is there? First, please start with. If you don't treat a bladder stage 4, what are the outcomes?
Not sure about the numbers, sir. 6
months to 1 year for the cancers. Okay. So if you take the most effective treatment regime for first line, what is it?
Dosed in Semvac.
Metastatic.
Yeah, no, metastatic.
In today's era, with best available treatment, with the newer drug, he's hinting towards that. But with
so maintenance with avelumab.
So what we have is first give 4 cycles or 5 cycles of cisplatin-based regime, then followed by Javelin.
Javelin 100.
Someone has mentioned in WhatsApp in the chat that is the drug which has a maximum survival, which is anyone can put in the chat. That's okay. Let's keep it 2 ways. Let's not question her only. It's not actually exam. So someone can tell me the pembrolizumab enough for survival. So whatever we do, now we have reached up to 2 years. The great difficulty. Otherwise, it is usually 1. So what is characteristic here is you start treatment, you give chemotherapy like cisplatin-based chemotherapy. Before you finish 6th cycle, it will progress. This is common in your hepatobiliary, common in bladder. Only thing is this Javelin study and this study has shown better outcome. So with that in mind, you have to get it right. The muscle invasiveness, you have to get it right, because if you miss it, you will have a progressive disease where your outcomes will be inferior. So, okay, if muscle invasive is there, what are the options are there? Neoadjuvant data, apart from what? How do you?
So it has to be a cisplatin-containing regimen. The two options would be dose-dense MVAC versus GEMSIS.
So, question comes here: if muscle invasive is there, whom will offer surgery directly? Well, like neoadjuvant followed by surgery. Whom will offer CTRT? What are the parameters you look? So, who are the patients who cannot be offered CTRT in muscle invasive bladder?
So what he wants to ask that what are the patients who can be an ideal candidate for bladder preservation? So how you will choose? But ultimately, you will give the option, patient and the family will say, doctor, you decide whatever you feel that. So when you have to take a call, what are the parameters you will take that this patient may not be a suitable candidate and this patient may be a suitable candidate for bladder preservation? Because indirectly the data for a bladder preservation, the overall survival of a bladder preservation vis-a-vis the radical cystectomy followed by a neoadjuvant, but more or less it has not been directly compared till this point of time. The OS is in indirect studies, there are indirect comparison, the UK based data sets, it's more or less equal. So how we decide in our OPD that this patient will need this?
So basically, based on the nodal status, actually, I could primarily assess whether the patient can go for direct CTRT or.
I think Vinayak, you can answer this. I think.
So actually, this is here and FWA, the same thing happens. The moment it comes, it becomes advanced. Till last, I think edition, it was metastatic. If you have a node, it was metastatic.
Yes.
Metastatic.
Yeah. Yes.
In fact, people is known for squamous cell. Squamous cell will have nodes more often, but transition will not have. If it happen, it is advanced. There you want to do neoadjuvant followed by surgery.
So in fact, Vinayak, the nodal, if the N2 is involved, most of the neoadjuvant chemotherapy trial, they have not included in the study. So it's only N1. So the moment the N2 is involved or N3, it's a systemic disease until proved otherwise. So if you read the inclusion criteria or neoadjuvant studies, in fact, in that initially they have not taken N1 also. With Niagara, they have taken N1 also, but in the previously the MVAC and the other CMV trial. So what Vinayak wanted to tell you that nodal involvement is until prove otherwise, it's a advanced disease and definitely for N2 and N3. So that is not the criteria that what he wants to tell you.
So let's split it out now. So patients whom you can do a partial cystectomy. So here also you'll preserve the bladder, but you'll do surgery. So which are the sites in the bladder where you want to do a partial cystectomy?
So if the primary is a single tumor localized to the dome of the bladder, if the vesico-ureteric junctions are not involved.
As long as your the reflex diffuse is not there, the junction is not there, you can do that one. Second, where you can't do it, with same thing, other area where you cannot do it, it's involved in trigon.
Trigon.
The two things it will rule out. Okay, the same reasons holds good for your CTRT or you want to do neoadjuvant followed by surgery. Okay, so this muscle invasive is fine. What are the new thing happened now? I think few people are quoting in the chat. So apart from your chemotherapy regimes, is there any new data has come in this subset of patient, muscle invasive, non-metastatic disease?
So what he wants to ask you, is there any data of adding some sort of a immunotherapy in this, and that is based on some trial which is being very discussed very often?
So there is data for adjuvant nivolumab.
No, adjuvant is not. We are asking about the adjuvant will be discussed later on, depending upon some fall, very famous fall.
So there are two ways you can do it. One, you can do perioperative durvalumab, or only other way is you do neoadjuvant adjuvant nivolumab. Some patients are not eligible for any of cisplatin. There you can use the immunotherapy. The 3 indications are there. So we have more slides. Sir, slides there.
Yes, slides are there. Yeah,
we can go because we have to cover testis. We have to cover.
Yeah, I think so the only summary point is that the role of the neoadjuvant chemotherapy with immunotherapy versus the adjuvant immunotherapy is rapidly evolving. So whether to give them the neoadjuvant chemotherapy with immunotherapy followed by some sort of a adjuvant immunotherapy or a perioperative for 8 cycle versus upfront surgery or neoadjuvant followed by adjuvant nivolumab. So at this point of time, that these two approaches has not been compared head to head. The role is evolving. So at this point of time, if patient is fit, the data for Niagara has shown the EFS benefit and probably OS benefit. And we know with all other indication like lung and all that, some sort of a neoadjuvant approach followed by few cycle of adjuvant immuno helps. We personally feel, that is, I personally feel that the immunotherapy should be integrated in the early part of the treatment rather than the later on adjuvant, because the better the path response rate, better probability of overall survival. So if you have to consolidate some treatments, better to consolidate on the new adjuvant aspect rather than considering for the, but both approaches are open or accepted. No one knows this one is better or that one. So this field is evolving. And another evolving thing is the role of enfortumab vedotin plus pembrolizumab in a new adjuvant setting, the EV302 trial. So that field is rapidly. So what Vinayak said, that in last 5 years, the euro has gone to a different level. So these are evolving at this point of time. You can answer that both approaches are there. If patient is affording fit, I may consider for neoadjuvant chemo with immuno followed by perioperative immunotherapy. And the other approach is also one of the options which can be considered. I think we can go to the other diseases. There are other. Next slide, please. I think we have discussed this already. So only thing is the cisplatin eligibility, which is being in the literature, that is mainly for a metastatic scenario. Whether we can extrapolate directly to the neoadjuvant, we have to be a little bit careful in this scenario, taking the these criteria that we can. And split dose we have to. The only thing is the split dose data has been. It's not a randomized trial. It's a small phase 2 studies which have been done and which have shown more or less same results, but still the level of evidence is not that high. But in day-to-day practice, we find it very useful, at least for initial first cycle or two, where we are not sure of the renal function. So clinically, it's in a practice, it's very commonly used, although the level of evidence is not that high to be recommended to level 1 evidence. Next. So I think next. Okay, that's an important question. Which no resident knows, because they have not going to the daycare and all that. So how you will administer nivolumab? What are the ways of administering nivolumab?
So you need a PVC-free set basically to administer nivolumab. It is given as 240 mg twice week, once and twice.
Is that only the dose option?
So the dose options are 3 mg per kg every 2 weeks, or it can be given as 4 mg per kg every 4 weeks.
Any other dosing option? We are not talking of the euro only. In the other disease segment. So you meant to say that there are only 2 doses is being used, either 3 mg per kg or 240 or 4 at T4 weekly. Is there any other dose?
I'm not sure.
40
so we give load.
The Indian innovation. Any other doses? So when we use cisplatin, gemcitabine plus nivolumab that is one of the other indication for advanced bladder cancer. You can use the upfront use of a nivolumab in a metastatic scenario. So where dose is 3 weekly, I think 360 or 340. So that is, so that we have to remember that this is not the only dose 2 weekly or 4 weekly. There are other dose schedule also. And any other preparation. So do you want to say that the only method of giving nivolumab is IV. Is there any other method to give, or any other drug which is any other way to administer nivolumab?
I am not sure.
Yes, I think someone had written that. So I think it's good to be exam on the Zoom, because you get an options from the other students. So someone has written SC. What is SC?
Subcutaneous.
Yes. So there is one preparation which has and this has FDA approved. So it's 1200 mg with, I think, the human hyaluronidase or some recombinant I think human hyaluronidase is that the so both will be combined and given in a monthly preparation of 1200 mg, which will avoid the use of visit to the hospital, the infrastructure use. So there is a FDA approved preparation for a subcutaneous use of a nivolumab, but definitely the preparation is different. Okay, I think next. Next slide, please. Next.
She probably has developed metastatic renal cell carcinoma.
So you have to complete the probably metastasis to the
with the vertebra.
Yes, yes. So how you will manage this case?
So what would she would immediately require a MRI spine with a screening spine, whole spine with a targeted area, followed by which she would probably require radiation therapy to relieve her of cord compression.
Only radiation, suppose.
And no, prior to that, we would definitely start her on steroids.
Okay. Suppose this patient had a recurrence after, say, 4 years and single site of metastatic disease to the cord, then whether your approach would have changed?
Right now, yes, surgery could be if it's a oligometastatic disease.
So in RCC we have to remember that. So the time duration itself is so in IMDC we know that within 1 year that's one point. So that and what we can send from our experience that some RCC are they present after few years, so after 2 year, 3 year. So try to go for a local treatment. If the disease recurs after as such no cutoff time, but in my personal experience, if it recurs after say 2 year and you want to go ahead, so go for the local aggressive treatment. If the time or recurrence from the initial surgery is more, and in some patient by doing a local treatment, you can just wait and watch. You are not inclined to give them the additional adjuvant chemo. So just remember the time duration from the initial treatment. So some patient may have a cord compression which may be surgically removed. Then you can give some adjuvant radiation and can wait. Other treatment of support in this patient when there is a recurrence within 6 months and multiple bony metastatic disease. Treatment options for a metastatic RCC. What additional information you want to proceed?
The histopathology of the disease.
Yes. Why?
Because there are histopathology. So if it's a clear cell carcinoma, then they are sensitive to TKIs. If it is a papillary, they are sensitive, but it's less so. There are other types of histopathologies that are not sensitive to therapy TKIs. So based on that, I would require.
Apart from that, I think someone is hinting you with.
And the volume of disease also. So if it is a
volume.
The IMDC risk also.
Yeah, so that is one of the falsity of IMDC, but they have not taken the organ involved and in there. So if you look IMDC, it's not whether a patient recurring in a brain, a patient recurring in the lung, both if the HB and all those parameters are, they will get the same number. So we have to IMDC risk stratification, that is important for this. I think Vinayak, you can take on with.
How do you approach a low risk or high risk, intermediate risk, or high risk thing? What are drugs?
So basically, it's dependent primarily on the histopathology. If it is a low risk, IMDC low risk, if it's 0, the options include basically a single agent immunotherapy agent can be given alone for them.
Clear cell?
Sorry?
Clear cell?
Clear cell. With TK, so the options include either IO plus IO or IO plus TK or IO alone can be given in case it's a low risk.
Okay. What is how classification is done? How is it done? Classification? IMDC.
So it is based on basically 6 parameters. One is the performance status. Second is the duration from the time of diagnosis. Third is the hemoglobin, whether it's lower than the upper limit of normal. Then the calcium level, if it is higher than the upper limit of normal. Then the neutrophil count and based on the platelet count.
So in a unfavorable, what you want to do?
So in an unfavorable, I would definitely want a combination of both IO and TK in case it's a clear cell carcinoma.
That's one option. Next option?
Next option would be IO plus IO and TK plus TK alone.
I'll ask directly now. Which is the TK you can prefer even if you don't, there's a contraindication for IO. So which TK you can prefer, single agent, in the guideline wise?
Single agent cabozantinib.
Category 1 preference is for what?
Cabozantinib.
Yes. So for similarly for low risk, what is a single agent preference?
Pembrolizumab.
TK. That's
Sunitinib.
and
cabozantinib also.
Pazopanib. So this two in the low risk you can give pazopanib and sunitinib. It's not that it should not give. For the data is for TK and IO is there. And your IO also is there, but you can choose that. Sometimes you don't have to give all the patients that. See, we'll get a good response even with pazopanib and sunitinib for select some patients. So whom you want to give IO, or whom you want to give IO and TK? Is there any rationale for giving anyone? What are you? How do you select a patient for both the therapies? See, if
So
the patient is very high, I'll give example scenario. Now the patient is come with the same thing. He's breathlessness. He's not able to walk. He's very sick. Do you want to give IO there, or you want to give just IO and TK? Which will work faster?
So both will be required if it's a if it's a high burden of disease, then both will be required, IO plus TKI.
Sure.
Not sure.
So usually you prefer IO TKI for patients who want your rapid onset. That's the plan. And second is CRs and response rates. What are response rates for IO combination and response rates for IO TKI? Any student, anyone can put in the chat thing also. Okay, that's one set question. So
which combination has best RR and PFS, but has not converted into OS?
Yes.
Hint.
IO plus IO.
Which there are three.
No.
So we use Nivo, Cabo, Pembro, Len, Pembro, Exi. So among what he's asking, the patient presenting with in this patient, multiple bony metastasis, severe pain, and you want to get a quick response, and then you have to choose among one TKI plus IO. So which one will you choose?
Pembro plus axitinib.
That has least. So basically the Pembrolizumab, that is one thing that Pembrolizumab is that it has a better response rate and have a better PFS, but that PFS and response rate has not transformed into the OS benefit which is seen. So in current era, for an intermediate and poor risk patient, not so much symptomatic, otherwise fit, which regime you want to give? Otherwise patient is fit, family wants a young 45-50-year male. One regime you have to choose.
Pembrolizumab.
then you have to read. I think someone is, I think the students which are there, they're very well read that someone has written the Nivo EP, and that is there. So the longest data for survival. So it's like a melanoma, where the data has follow-up data has come up for 10 years. Similarly, the 96 months, so close to 8-year follow-up data for IU plus IO has already been published, and that was the last analysis of that data. So the longest survival at this point of time is seen, or the best survival seen is with the IO plus IO at this point of time. Only thing is that the right patient selection, the toxicity, all of these are important. But if you have to pick up one among those which is best in terms of the OS, it is still the IO plus IO. In fact, what the discussion was going on, that even in a low risk patient, IO plus TKI has not shown OS benefit till this point of time. It is the only PFS benefit. In fact, Pembro XG has not shown DFS also. So it's the only Pembrolizumab and Nivo-Cabo has shown PFS benefit. So if someone wants to use single agent TKI in a asymptomatic, not much symptomatic patient, you can give the TKI alone and use the immuno at the time of progression.
So someone has asked how to sequence it. For my practice, I can tell. See, I would prefer if I'm doing IO, I'll do for patient, because it's the closest we get to single agent drug. You only give 4 cycles and then followed by IO only. So that is the closest one we get for single agent. Otherwise, if I'm preferring IO and TK, first line I would prefer Cabo and Nivo.
Yes.
Because there's a second line data, good data about lenvatinib with everolimus. So I would have that option as a second line and prefer Nivo and Cabo first line. But for various reasons, sometimes it happens that patients don't tolerate Cabo so well, despite all the modification. There we want to use Examinee, because the Examinee half-life is very short. There you want to use Examinee with pembrolizumab. Otherwise, lenvatinib and pembrolizumab, I don't think most of people prefer, because they want to keep it for second line. So hope I answer that one. So other question is the same question. So if you have a variants like other non-clear cell, is there anywhere you can use chemotherapy regime in a RCC? Or you use different regime at least? So what is unique about all those atypical ones? Other non-clear cell, how you approach the stage 4 non-clear cell RCCs?
So papillary renal cell carcinoma is mainly managed with TKI alone.
Only TKI. So you want to, suppose the pathologist has given papillary RCC. So I think you have not worked with me. That's why I think so. So what we want to know, whether it's a papillary type 1 or
Type 2.
So why we want to, and what marker we see in histopathology? When we read the histopathology report, I tell the agent to read full report. So pathologists will write so many ISC markers, but apart from MET, I think Tanis is so apart from MET, what we see, ultimately the purpose of reading any report is whether we change the treatment, or as a clinician we want to change the treatment as per the histopathology report. So what histopathology, or which ISC you want to see in the papillary RCC with the pathologist has done or not, which may have an impact on the type of therapy or the treatment we are planning. So it is the fumarate hydrase, FH. So mostly papillary type 2 may have a FS deficient tumor. They may have a familiar tendency, and there is a good data that bevacizumab plus erlotinib gives those patients a decent PFS of close to 22 months. So papillary type 2 RCC with FS deficiency may have they may respond well. It may be a part of a syndromic. The other thing is that if FS deficient tumor is there, you have to look for the other FS deficient, the uterine fibroid, skin manifestation. So only papillary is not sufficient for us. The other thing the pathologist reports is the succinate dehydrogenase, SDHB deficiency. Although the treatment is not changing, but there are other syndromic approach. So if there is SDHB deficient, you have to look for the other syndromic approach, other possible tumor in those patients. So you have to look for the SDH and the FH, and FH has a treatment implication. And the question Vinayak was asked, is there chemotherapy? Rarely. What are the other variants? So papillary is the variant, chromophobe is the variant. Name some other rare variants which we see, at least in Tata we see 2 or 3 or 4 cases in a year.
SDH deficient is there. Then there is hereditary leiomyositis with RCC, which is FH deficient again.
Yes, that we discussed.
Then there is collecting duct RCC is there.
Yes. So now you come to the collecting duct and the other which is associated with some of the
cystic disease, acquired cystic disease associated RCC.
That is one thing with that one associated with one blood disorder that is seen in patient with some blood disorder. I think everyone is very prompt. So it's the renal medullary, the SMARC B deficient tumor. So
SMARC B deficient.
Yes. So these are the tumor. So renal medullary cell CA and maybe collecting duct tumor, we treat like a urothelium. We may consider, so for collecting, there is a data of a cabozantinib also. So we can use the chemotherapy in either in collecting duct or in a renal medullary. So these are the two which Vinayak was asking, the role of a conventional chemotherapy in RCC. Vinayak, you can take further.
We have testicular tumor, sir, slides, or we'll talk about. I think
yes. I think someone is asking some question. रश्मि रंजन, ये तो अपने रेजिडेंट है, राउंड में तो कुछ पूछता नहीं है, यही पूछ रहा है सब.
So actually, so I think my experience with Lenva and everolimus, more of trouble is with mucositis than diarrhea. Usually, the trials do speak dose reduction in a different way. Practice is totally different. For example,
Yes.
let's just give example. TKI, you should remember that slide of Dr. Ma'am that put that half-life of each one. So for example, if you have a very long half-life, you can do alternate day. If you have very short half-life, you can give break Saturday, Sunday, something like that. So that will make the drug effective with break in the toxicity. So that is, I think even in international experts where I spoke to them, they sequence TKI in a way that the effect is there, side effects are less. So that should be there. So we'll go for last testicular tumor. I think it is being covered a little bit in a hurry. So we have to be very, see, then one of the long case will be.
I think the sequence should have been reversed. The testis should have been the first and the other would have. So don't worry, I will take the Anupa's class in TMS to conclude that.
The testicular tumor, we have to be very, very, very thorough with all 4 drugs. The drugs are there for 20 years. Sir wrote exam, same drugs. I wrote exam, same drugs. You are writing the same drugs. And I think it will go for a long time because it has achieved 95. Maybe some immunotherapy may just squeeze in for relapse disease, but that's how it is. So I think for my side, this is a very good session. And especially the slides, if they share, or I think it's on YouTube, I saw the previous one. You can always come back and see the video. Each time you see a video, you'll get a different perspective. That's how it is. Those videos learnings are. There is learning, incremental learning and repeated watching. So Amit's the last words. And I think Hemanth, if he's there, we can have him a few words later.
What I can say that it's a very good initiative. I'm first time joining this, but it's very useful. And the attendance on a Sunday when the India-New Zealand match is going on, so it's 95, close to 100 attendance, and it's remarkable. And I will congratulate the initiative taken by this Dr. Prashant and his group, and Dr. Purvis, the icon. So it's a really a pleasure to talk to all of you, all the students, and whatever we learn. So what I tell the resident that it's not only the theoretical part, the practical part, but we have over a period of time that they should also learn from that what we have learned over a period of time, and that is the purpose of the teaching, that the nitty-gritty of any subject. Otherwise, everything is in the chat GPT today. So you can answer the question, you will get the question, and you will get but the real life implication may be different, and that is the way we as a teacher, we are trying to help all of you. Definitely, you get a time and you want to discuss a full GCT case, we can keep in any of the weekend, we can take a full GCT case for 30, half an hour like exam case. That will be helpful for all the students.
Thank you so much, sir. I'm really grateful to you, sir, Amit Joshi, sir, and Vinayak Maka, sir, for your expertise, for taking out time on a Sunday. It was a very engaging and insightful session, sir. We all learned a lot. I'm also grateful to our speaker, Dr. Chandralekha, for putting in all the efforts.
Yeah,
I'm grateful.
her slides, I think if that can be shared to the residents, they can, at least those who want to read, that's a good quick review of all the important drugs. It's very, very well made slides.
We will definitely share the slides, and also the video will be uploaded on the YouTube, sir, so that students who could not join today for some reason, they can also watch it later, and they can also use it as their study material for exam preparation, sir. I'm grateful to Hemanth Kumar, sir, for his insights, for being the driving force behind this presentation. I'm grateful to Vidit Kapoor, sir, for being the program director for this session. I'm grateful to Dr. Anupa for volunteering to be an examinee. It really takes courage to be here in front of hundreds of students. So kudos to you too. And I'm grateful to entire Icon Amrita team for great academic initiative. And we look forward to meet you all again next Sunday on the session on malignancies related to female genitourinary system. And the examiner is going to be none other than Dr. Padmaj Kulkarni, sir. It is going to be moderated by everyone's favorite Dr. Deepa Suzanne, madam. Dr. Deepam Pushpam, sir, is the mentor for this session, and Dr. Munir is going to be the speaker. Looking forward to meet you all next Sunday. Thank you so much. Have a great weekend. Thank you.
Thank you.
Thank you.
Thank you, sir.